Welcome to Moving Medicine, a podcast by the American Medical Association. Today's episode is part 2 in a discussion about the physician shortage and how to fix it. If you missed part 1, you'll want to go back and give it a listen. AMA experts in today's episode are immediate past President Dr. Jesse Ehrenfeld, Dr. John Andrews, Vice President of Graduate Medical Education Innovations, Senior Attorney Alexis Pierce, and Christopher Sherin, Assistant Director in the Division of Congressional Affairs. Here's Dr. Jesse Ehrenfeld.
Let me bring John back into the conversation. So addressing the workforce shortage is also an important health equity issue as well. So how are these workforce shortages impacting, in particular, underserved communities across America?
Well, Jesse, I think you answered that question in your introduction with the anecdotes you shared about access to care, cardiologists, obstetricians, your parents. The inability to access care is in and of itself a health inequity. But more importantly, when access is compromised, it leads to delays in care, delays in obtaining care, that lead people to more advanced stages of disease when they ultimately find appropriate care. And that leads to inequitable outcomes. The populations that suffer these limitations in access are the very ones that are suffering much worse health outcomes as a direct result of their inability to be cared for by the physicians that they need.
So, John, there's a lot happening within the medical education unit at the AMA. Can you walk us through some of the projects in the Change MedEd initiative that you're involved in that are trying to address this workforce issue in particular, and how some of those efforts might be linked to some of our work in health equity?
Sure. I'll mention a couple of them that I'm quite familiar with, just as examples. I oversee an initiative called Reimagining Residency, which is working to innovate in the graduate medical education space. And one of the projects that we support is a collaboration between UC Davis and the Oregon Health and Sciences University to address workforce shortages in communities between Sacramento, California, and Portland, Oregon. Many of those areas rural and many of those communities indigenous. And the model that they're evolving is to reach into those communities to recruit people into careers in medicine to serve the needs of those populations, because they know they're the very people who are most likely to return to those communities to serve. And then during their education in medical school, and importantly in residency, they're delivering that education in those communities so that people are training in the environments where they'll have familiarity with the resources that are necessary to provide effective care. And so we think that shows a lot of potential for serving the needs of those communities with people who are culturally and in many cases racially and ethnically concordant with the populations whom they would serve. On the other coast, there's a project at the University of North Carolina called the Fully Integrated Readiness for Service and Training Project. This is an evolution of a pilot they've had for a while that attempts to truncate training for people who are committed to careers in primary care. So they have a 3+3+3 model, 3 years of medical school, followed by dedicated transition to 3 years of residency in family medicine, and then 3 years of mentored practice in a rural community in North Carolina, once again working to meet those workforce needs. And with our support through Reimagining Residency, they've expanded that model to other disciplines, including surgery, pediatrics, and psychiatry, to address deficits in access to care in those disciplines as well. That is shortening the time to get these people working in those communities, and importantly, providing them a dedicated path to careers that they aspire to.
Well, Alexis, John, Chris, what a great discussion. How do we incentivize more physicians to train and or practice in rural and underserved areas?
Well, I'll leap in and just say that I think incentives are important, but I want to fall back on this strategy that I talked about earlier, which is to think about whom we're training. And where those incentives from a background standpoint come, in addition to any sort of financial or loan forgiveness incentives we may offer for practice in those communities. I think we need to think really carefully about whom we're training and whether those trainees are likely to meet the needs of the communities that most need them.
That makes a lot of sense. Alexis?
I agree. Sorry, if I could. So just like expanding on that, I think that that's right. Whenever we're advocating, with the administration around the Hill, we look at this problem holistically, and we advocate for everything from starting, integration and knowledge about being a physician to like elementary school students to, asking them to think about mentorship and how that might look through high school and college and through the application period for medical school. And, all the way to having communities play a more active role in how they promote and talk about like the physician profession. And then of course we talk about it all the way through funding, so increasing access to things like the National Health Service Corps and expanding that to additional practices that can be involved there. They've recently expanded it to OBs, which is fantastic, with maternity care target areas. That's something that we pushed for, and all the way through to the very like core of how public service loan forgiveness is enacted. And we worked really hard to make sure that even physicians who weren't directly employed by their employers, so for example, in Texas and California with the corporate practice of medicine, that they can still access those beneficial programs. And of course, we touch on those same similar service programs through the Indian Health Service and a few other, the Veterans Service, those few other things. So we think it's really, we try to address it all the way through. And then of course, keeping them in practice, like Chris had talked about with fair payment. So yeah, thanks.
I think this next question is for Chris. It's a long one. How does the CBO score of HR 2474 impact its political viability? Challenge, no doubt, but Congress has the entire federal budget that it might pull from. Where do you see this going?
Yeah, so this was actually my attempt to answer that particular question that I got. So you were exactly right. The questioner is in terms of what is the political challenge. We don't have an official CBO score, and it is a costly bill, but it's not insurmountable as it relates to the MEI. And really what I want to emphasize is that AMA isn't typically in the business of selecting offsets for these types of pieces of legislation. That's largely why Congress is there. They have the entire federal budget at their disposal, and there is plenty of money that they can pull from if necessary. What I will say, though, is that it is a challenge, but even if we can get, say, a 2 or a 3 year down payment, if you will, on an MEI, that does serve as a springboard for permanent reform. And I think we just have to recognize that, particularly in this particular climate, we have to operate within what's possible and what's readily available for us. And that's what we're trying to do as best we can.
That makes sense. So, obviously we're the AMA, we work at the federal level, but we obviously all work with our state partners and the rest of the Federation of Medicine. Let me bring it down a level and ask, what can state policymakers do to piggyback on some of those solutions we've talked about to try to address some of these physician shortages?
I think Alexis and Chris can speak to their legislative responsibilities, but one of the important things I think we need to recognize is that many of these disparities are regional, and people at the state level are probably in the best position to understand what the needs of the populations are locally. And I think a central, federally supported solution to many of these problems is going to be less effective than people who are on the ground in those communities and know what the needs are.
Chris, Alexis? State policy options that might help us.
I think that obviously states can and have enacted their own recruitment programs as well as their own repayment programs. Additionally, states can fund their own residency slots if they so choose to, and multiple states have chosen to do that. We have a GME compendium where we have, a kind of collation of some of these efforts. So if you are interested in that and you have some sway with the state or you work for your state, I would encourage you to maybe take a look at that as a starting point, because you can see how other states have successfully integrated and implemented some of these systems into their own healthcare system. And John's right. So that way you at the state level can target your needs, and you can put in requirements to either work in certain areas or promote certain specialties that you're seeing that are particularly needed in that area. And I think that actually you have a ton of control at the state level to try and help some of these underserved areas or deficiencies that you might be seeing locally.
Chris, other thoughts?
No, I think that's very well said. I don't have a whole lot to offer in addition to that. I do think the fact that states can try and fund their own residency programs is hugely important. Obviously, they have their own budgetary constraints as well that they have to operate under, but it is an important fact that often gets overlooked.
So let's stay at the state level. What can our medical societies do around the nation to help with some of these physician shortages? Are there any particular type of collaborations that you all see as most helpful or useful or productive?
I mean, I can jump in a little bit on this one. I think as it relates to the bills that we've described, whether it's the Resident Physician Shortage Reduction Act, the READY Act, the SUD Workforce Act, the states can get involved as it relates to grassroots advocacy, pushing for additional co-sponsors, pushing for legislative action on this. So often federal elected officials want to hear from folks back in the state and local districts, and that's where you can play a real great role in this. You also are so adept at localizing these issues. Individuals like me will often talk about the federal impact and just the nation in general. What the elected officials want to hear about is how it's going to impact them on the local level. And that's where the states can be so invaluable. So those are things that I would suggest for the states to get active in as it relates to this workforce issue.
Makes a lot of sense. So let me ask maybe a pointed question. Is better compensation and less charting in the electronic health record the answer to our physician workforce shortage problem?
So I think it's an interesting way to say it. And this is, again, where I'm talking about kind of the localizing, the personalization of these particular issues. A member of Congress or even on the state level is probably not going to know a whole lot about charting, but what they will understand is administrative burden. And I think you can stress that that's one part of it. When it comes to compensation, I think it's very clear that we need to do something about Medicare physician payment reform, and that's compensation. And so you take the combination of the three bills that we described on Medicare physician payment reform, as well as burden reduction, things like prior authorization, step therapy. Those are things that will undoubtedly help the workforce crisis because it'll eliminate burnout and it'll also keep the existing population of practicing physicians in the practicing setting, and that's what we really want.
Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/movingmedicine.
Let me ask John this next question. How do we make sure that our new physician workforce, our growing physician workforce, is racially diverse and able to meet the needs of the communities that they serve, particularly given some of the challenges around the ending of a lot of affirmative action programs with the Supreme Court ruling last summer?
Yeah, so I don't want to sound like a broken record, but recruitment efforts are important. Again, we need to make sure that we're reaching out to train the right people. And many of the institutions with whom we're partnering in our unit are adopting some very creative approaches to look at distance traveled to a career in medicine that are independent necessarily of objectification of race and those sorts of things. So I think we need to get the right people into medical training, but importantly, we have to create paths to success for these people as well. We know there's differential attrition from our training programs among certain groups. It's a particular problem among Black men, where attrition from residency far exceeds the rates for other groups. And there are some cultural and structural issues in our medical education programs that need to be addressed to ensure that someone who pursues a career in medicine is going to be successful and ultimately serve the populations that we hope they will.
Well, speaking of Black men, I will say that one of the most magical functions that I've been a part of locally was a Black Men in White Coats Youth Summit that we hosted in Milwaukee at the Medical College of Wisconsin. 600 plus kids and their parents registered to come, sixth graders on up, learn about going into the health professions, to hear from folks that looked like them, to see that they can be in the health professions, medicine, and others. And I think those opportunities to really open people's eyes and make sure that people who have the capability aren't pushed away because they don't consider the possibility or they haven't seen somebody who looks like them in medicine. Let me ask this next question. How do we affect a performance-based standard with ACGME or ABMS to shorten the time to certification so that we get more talent out onto the front lines sooner and out of these time-based approaches to training?
Yeah, we are very time bound in medical education. And so one of the structural barriers we have to address is the fact that the current currency for licensure or certification in medicine is the time spent in training rather than the competency achieved. And so we're working hard to develop reliable measures of competency that we can advance to say, I know someone's only been in training for a certain period of time, but they're ready for independent practice. We're not there yet to a level that's acceptable for things like state licensure and board certification, but that work is ongoing. I will highlight, however, that there are paths that already exist for committed learners. There's a consortium of accelerated medical pathway programs that offers 3-year pathways from medical school into certain residency disciplines. For example, I described the first program in North Carolina. So there are some people taking some practical steps to do that. But time variability is a big issue in medical education right now that really rests squarely on the shoulders of assessment.
There's a question that popped up, which we may not have a specific answer to, but I think the idea is clear. What percentage of IMGs coming to serve in an underserved area then go on to a better paying specialty training or job somewhere else after they do what is maybe required? Do we have any sense of that?
Yeah, I was trying to dig for the exact numbers because I have it somewhere, but really the retention rate is really high.
Yes.
They tend to stay in the same area where they've been serving after the Conrad 30 program, or if they engage in some other sort of waiver program through like the HHS, the VA, whatever it might be. And it's significantly higher than their US born counterparts because they tend to integrate into the community. They stay, they build a practice, and really, so these programs, these waiver programs have been extremely successful and more successful for IMGs than for, native born physicians. So I would say that, yeah, the stronger we can make them, the more likely we are to have them integrate permanently.
It makes a lot of sense, and it's sort of where you land and where you get set up and where you get integrated into the community is so important. We certainly see that as we think about creating some of these rural training opportunities at the GME level. The data that I'm aware of is that 80% of residents will practice within 80 miles of where they do their residency training. So if we are able to expand those rural training pathways, obviously there may be some additional benefits. This next question is long, and I think there are a couple parts. So let me take it piece by piece. The first piece is, how is the AMA presently advancing equity for those underrepresented in medicine clinicians who are in training and in the workforce today?
Yeah, so it's a great question. We are advocating for a more diverse physician workforce. I think the Conrad 30 legislation is part of it because if you have international medical graduates who are not born in the United States, do not go to an American or Canadian medical school, and they come to the US for residency, and then they're allowed to stay, as we just described, it's very likely that they're going to stay in those rural communities. So not only does it help with the workforce crisis, but it diversifies the physician workforce, which is so important. There's also different parts of the bills that I've described that are tried to focus on this particular issue. The Resident Physician Shortage Reduction Act, for example, has a GAO study mandated in there to try and look at how we can get more minoritized and marginalized populations within the physician community. And it also tries to talk about strategies for that too. So I think the combination of some of the bills that we're already referencing, as well as some of the components that maybe are less known in the bills that I described are ways to do it. You also can talk about the connection with the historically Black medical schools as it relates to where those residency slots would go. So I think the combination of those things are really great ways to show how we're fighting for a more diverse physician workforce.
Okay, the next part of this question, oh, go ahead, Alexis.
No, go ahead. It's okay.
No, I just said the next part of this question is, I think, asking how do we balance or prioritize advocating for recruitment of more international trained physicians into the US while also thinking about how do we get fair treatment of our US based, US born underrepresented physicians. And I would say that it's not either or, it's both. We have to do both. And we would never think about prioritizing one versus the other. It's full stop. We need both, and we won't stop until we achieve it. But Alexis, maybe you wanted to jump in.
No, that's okay. I totally agree with what you said. I think it's a both approach. We need all hands on deck. We've talked about the shortages we're going to experience, our aging population, so our shortages might grow, actually. And I think that we want to advocate from a holistic perspective. So just echoing what you said.
Curated from more than 3,000 major newspapers, magazines, and journals, the AMA Morning Rounds newsletter delivers the top stories in healthcare right to your inbox, Monday through Friday. Subscribe today and check out all the AMA's free newsletters at ama-assn.org/myinbox. That's ama-assn.org/myinbox.
Perfect. Well, I do want to give each of our panelists just a minute to provide any other summary comment on priorities that they see in the years ahead, and then I'll give us some closing comments. And maybe I can start with Alexis and then go to John and then end with Chris.
I think it's just we are truly working holistically to try to address this from every single angle for, underrepresented, physicians who are born in the United States, for international medical graduates, for practicing physicians. And we take on that in almost every single statement that we submit to the administration, to the Hill. And I think that if you do take some time to go through our letter finder, you will see that we've looked at this from so many different angles, and we support a plethora of bills and rules and proposed rules that we didn't even get to touch on today because of the time constraints. So I would really encourage people to look at our graduate medical education compendium and to look at some of the great work that John Andrews' team is doing on our med ed portion of our website. And thanks for spending the time with us.
John, any closing thoughts?
Yeah, thanks, Jesse. I'm going to reiterate something I said at the top of the conversation, which is to not reduce this to a simple capacity issue. It's really a geographic and specialty distribution issue as much as it is a supply issue. At the risk of countering a point that was made earlier, there's plenty of capacity in our GME system right now. There's a lot of talk about the fact that GME is a bottleneck, that there aren't enough residency positions for U.S. medical graduates. There are 1.4 positions in the residency for every USDO and MD grad right now. There's plenty of opportunity, but the individual choices that people are making about where they train and what they train in are influencing U.S. graduate engagement with the workforce. And I think that's where we've got some work to do.
Well, certainly everybody wants to be an anesthesiologist, which doesn't perhaps help. All joking aside, that is an important point about that mismatch, right, between what's available and what we have the capacity to provide. Chris, closing thoughts.
All I can provide is that I think we, as the AMA, are trying to put forward real concrete solutions. And as John mentioned, it's not just simply a capacity issue. I think this is a multifaceted issue that requires a lot of different types of solutions. And you've heard from us about the different ways we're trying to tackle this. We can't just look at it from training more physicians. We can't just look at it from targeted immigration reforms. We also have to incorporate payment reform. If we can achieve all three of those things, I think we're in a great spot. And I think we're serving the membership well by looking at this issue a little more holistically and beyond just the narrow focus of trying to train more physicians.
I think that makes complete sense. The physician workforce trends that we went through today are really concerning to everybody who works in healthcare and to everybody who relies on the healthcare system to recover from an injury, get through an illness. That means everyone. But the situation is clearly not hopeless. There are real solutions out there that we can help grow and strengthen our physician workforce to meet the health needs of a changing America. I want to thank everybody for your time today and for being so engaged with us on this issue. Thank you.
This has been Moving Medicine, a podcast by the American Medical Association. Subscribe today to never miss an episode. Thanks for listening.